You may be wondering who this very handsome man is here. And I had a problem because I wasn't sure, is that me or was it me? I wasn't sure what tense. But that was me about 20 odd years ago. I had hair, the first surprise, and it was that colour. That has not been photoshopped. I was very proud of that colour. It is genuinely great to be here, and I'll be talking under the unusual title of Anarchism, Punk and Evidence-Based Medicine. I'll specifically be focusing on the systematic review process and at times the Cochrane collaboration. A bit of background about myself. I've been involved in the evidence-based medicine world for about 16 years now. Most of my time has been answering clinical questions for general practitioners and primary care health professionals, and I've run various services. And over the 16 years, me and my teams have answered over 10,000 clinical questions, so that's a fair few. I also run the TRIP database, the evidence-based medicine search tool, which many of you will have heard of, and I've been very pleased that it's been mentioned an awful lot over the last couple of days. And we're now well into we've had over 100 million searches of that since we started it. I also have the pleasure of working for Public Health Wales, setting up the evidence service there. Here, well, anarchism's a broad church. It's sort of self-proclaimed anarchists and the people who express anarchist-style tendencies. You've got classics such as Noam Chomsky, Kropotkin. I love that beard. I'm very jealous. My girlfriend wouldn't allow me to grow it that bushy. And at this stage, I need to owe people a sort of apology. I promised sex, drugs, and rock and roll in my teaser abstract, and this joy of sex is going to be the only real mention of it. Because, good, no one's leaving. They're expecting lots of sex. Anyway, Alex Comfort, who wrote The Joy of Sex, was a doctor, but he was also an anarchist, and he's written many anarchist books and pamphlets, so I've included him. Emma Goldman down the bottom. And then you've got the sort of non-classical anarchists. You've got people like Max Weber and Nietzsche. And one of the things you often associate with anarchy is sort of discord and disharmony. But I don't know if many people know, but in the middle of my slide there, it's an A surrounded by the O. And that actually signifies anarchy as order, and anarchy means order. And for me, anarchy is about examining power, looking at authority and hierarchy, and generally being pretty cynical about them. I put this slide of some of my favourite punk bands, and I was struck by how stuck in the 80s I am. It's really quite tragic. Dead Kennedys, Chumbawamba, Conflict, Butthole Surfers, Black Flag. These are all sort of musical sort of embodiments of anarchism. And for me, they exemplify passion and speed, things that seem to be lacking in the evidence-based medicine world. Well, speed for sure. And I'm not, another thing that they associate with punk is anger. And I'm not really an angry person, but in putting together this slide, I did actually find myself getting quite angry, which was a surprise. And as I go through my talk, perhaps you'll see why. This Sisyphus, poor old Sisyphus, punished by the Greek gods for defying them. He was punished for eternity by having to roll a large rock up a hill, only for it to be flicked down and for him to have to start again. I think the similarities with the systematic review process are there to be seen. Albert Camus, existentialist goalkeeper, not many people know that, an anarchist, wrote The Myth of Sisyphus. And in that he used the Sisyphus pushing up the rock to explain the futility and absurdity of human existence. And again, the more I look into the systematic review world as it's going, I just again see that futility and absurdity. Ooh, too keen. Many of you will recognise this man, Ian Chalmers, a true great of the evidence-based medicine world. He's been very, very kind and patient with me over the years, and I've learnt an awful lot from him. For those of you who don't know, in fact, probably you all know that Ian Chalmers was one of the main driving forces of the creation of Cochrane. And when I first really knew Ian, this is about 5 or 6 years ago, this was in the middle of answering about 50 clinical questions a week. I said to Ian, very humbly, I'm sorry to say, Ian, I don't find Cochrane that useful. It doesn't answer many questions. And Ian taught, we had a good chat, and then at the end of the conversation I said to Ian, this is the deal, I'll like Cochrane when it answers 10% of the questions I get, which I didn't think was too high a bar. I'll develop on that theme a bit later on as well. Another thing that links Ian and myself is a love of Noam Chomsky. And I love this quote. I think it only makes sense to seek out and identify structures of authority, hierarchy and domination in every aspect of life and to challenge them. In the evidence-based medicine world, we're quite good at doing that in certain situations. We're very good at attacking the power base of pharma, really good at that, alternative therapies and exposing them. But I don't think we're very good at looking at ourselves and applying the same principles, and I think that's a great shame. I think we all need challenging. And this equation I used when I presented 2 years ago at the last Evidence Live by Slawson and Shaughnessy. The usefulness of medical information equals the relevancy times the validity divided by the work. So how relevant is this information to my clinical practice? How valid is it? Is it robust methodologically? And how much work does it take in getting to it? As I said earlier, I've answered 10,000, me and my various teams have answered 10,000 clinical questions. And we did examination of 358 dermatology questions. And we looked at what type of evidence answered these questions. And of those 358 dermatology questions and answers, only 3 were answered by a single systematic review. Some might say, well, dermatology is atypical. We haven't formally examined other areas, but it's certainly not atypical in my experience. Some are certainly better, but none of the specialty areas got close to 10%. I think we'd be lucky if any of them got to about 3%. Validity, for the sake of this talk, or for the sake of this slide, anyway, we'll say that, systematic review methodologies as characterised by Cochrane was a high validity. The work, well, we know. The work in producing a systematic review is massive. 2 years, hundreds of hours, if not thousands of hours. So you feed these variables into the equation. Relevance, low stroke moderate, being generous, I think. Validity high, and work extremely high. What gets chucked out makes you question the usefulness of the likes of Cochrane. And in my exploration through the systematic review world, I've spoken to many, many people, and a couple I'd like to quote. Paul Glasgow, I think, at the back. Hi, Paul. We're talking about waste in the systematic review process. And with particular reference to Cochrane, he said they've raised the methods and process barriers so high that most are not being updated. It's fairly uncontroversial. And then he talked to Tom Jefferson, who's talking in one of the other rooms. And over the course of our number of emails, I summed it up by saying basically the systematic review system, as characterised by Cochrane, is broken and clearly unsustainable. Is that a bit harsh? And Tom's reply was, I think it looks like it for drugs, biologicals and devices. Sorry?
What's that?
Well. And what Paul is, so bringing this back here, Paul was saying that they've made the methodology so high that it's just virtually impossible to update them. And Tom's saying they're not going, the methodology isn't going high enough because they're not using regulatory data. I think what we've got is many systematic review producers are falling between 2 stools. Taking on Paul's point about being very difficult to update, this is taken from the Cochrane Library Oversight Committee less than 6 months ago. And 2009, they reported that 39.8% of their systematic reviews were up to date. I thought that was a mistake. You will not believe the amount of times I've reread that section, because I thought it was proportion that were out of date, but it's actually proportion up to date, 39.8%. But then we fast forward to 2012, and it's gone down to 35.8%. Does anyone think that's good? I think it's appalling. And the trend line is clearly getting worse. Open access has been talked about, and I understand David Tovey touched upon open access, but I don't know what open access means. But, well, it has many different meanings. I think Cochrane should be open access. I think people should be able to freely access Cochrane data and use it as they see fit. I, as a UK taxpayer, I help pay a block grant to Cochrane, which is fine, no objections to that. But then, as a UK taxpayer, we have to pay again to view that material. I think that's bizarre. I'm also very jealous because in TRIP we don't have such a great business model that we can do that sort of thing. But in relation to TRIP, I'm not talking about TRIP particularly, but I wanted to put controlled trials in the TRIP database. It seemed an oversight that we've been going for 15 years and there wasn't a filter for controlled trials, considering their importance in the evidence-based medicine world. And so, who's got the best controlled trials database? Cochrane and Central. And so I approached Cochrane saying, oh, can I borrow Central to put in TRIP? No chance. It wasn't a formal no, but it was told, probably you've got no chance. So what did I do? I could either throw my toys out of the pram, but I built my own, and we launched a controlled trials section in TRIP with about 500 controlled trials. But for me, what annoys me is that, from my understanding, Central is almost exclusively taxpayer funded, and yet they were preventing me use it in a way which I felt would improve patient care. That's verging on harm. But then the other thing around open access is, at the moment, there's a lot of talk about pharma being open, and pharma giving all their trial data. Brilliant, got no problem with that. I just wish Cochrane would do the same, because I know if pharma give all their trial data to Cochrane, Cochrane will wrap it up and they'll charge us for it. I think that's sort of hypocrisy. I had to get this slide in, one of my favourite sort of anarchist slogans, no gods, no masters. And for years, I feel being a bit bitchy about Cochrane, but I wouldn't be the first at the conference. But no gods, no masters. For years, I've joked about Cochrane being a bit of a cult. I'm on the outside. And I think you've got a secular priesthood, those who sort of at the top of the tree of Cochrane, the paid people. Because none of my criticism, by the way, of Cochrane is directed at any of the thousands of volunteers who are almost exclusively well-meaning and do a wonderful job. These are for the sort of, as I say, the secular priesthood, those at the top of the tree. They've even deified Archie Cochrane. He's got this godlike figure. And what I think, I showed sort of Max Weber earlier, he's got this comment about charisma or authority. And I think what Cochrane have achieved with Archie is charisma or authority by proxy, which I think is brilliant. But I think it stops criticism. Oh, look at Archie, isn't he nice? And I think it's dangerous because you don't get much criticism. I spoke to Ian yesterday evening, and he did say there is a prize in Cochrane for criticisms, which I think is wonderful, and Ian paid for that. I think that's a wonderful thing. But I didn't know about that. And I don't know what the criticisms are because I never see them. I'm on Cochrane almost every day. So I think criticism of Cochrane would do Cochrane good. But one of the things is that Cochrane is now big business. This is taken from their annual report and financial statements, 2010 to 11. These are some big numbers here. Sort of about 17, 18 million pounds a year. If you add that up over those 7 years, that's over 100 million pounds. Cochrane have been going for 20 years now, and that's going to be about 150 million pounds. That's $250 million. These are vast sums of money. And if you look at the last 3 years, the last three bars here on the income, on the blue line, I imagine that's when they teamed up with Wiley. So there's a significant increase in funding. But if you go back to the slide of the number of systematic reviews that are up to date, that's got worse. I can't reconcile that. I'm sure someone at Cochrane could, but I'm sure there's a simple explanation. But looking at it, I just don't understand it. And I think we need to change, because I think the current system is just unsustainable for Cochrane and for other people involved in systematic reviews. I'm based in Bristol, by the way. Banksy, the graffiti artist. This is a stylized image. I don't actually know if it's a genuine Banksy. I think that's part of the things with Banksy. You don't know if, he's true, if it's a real one or not. But it came up, so I'll use it. But we need change. I want change. Because ultimately, this is about me helping clinicians get access to robust evidence. I want my job of answering clinical questions. It'd be great if every single question that came in from a GP or a practice nurse could be answered by a single systematic review. I would love that. It'd be easy. Make my life so much easier. And my team, who are here now, would make their lives easier. But change is coming, and change is happening. A great paper I saw recently, Hemmons and Haynes, looked at updating systematic reviews, Cochrane systematic reviews, not using all trials, just using a sample of trials from evidence updates. And it found that using just the evidence updates to update the systematic review made no difference of the effect size of the subsequent systematic review, based on the subsequent Cochrane update of their systematic review. And I apologise to any Italians here, but there's a recent paper by Sagliotti, which used a pragmatic strategy for the updating of systematic reviews. You can have all these references afterwards. And again, they use a different method of updating Cochrane systematic reviews, just using the top impact factor journals in a particular speciality. So it was the cardiology systematic review, they just use the top impact factors in cardiology. And again, no difference. A paper I did 2 or 3 years ago now with Paul Gladue and others in his team in Oxford, we looked at the how often the largest randomised controlled trial agreed with the subsequent meta-analysis. More often than not, I think it was about 80% of the time, there was a complete agreement. And if the largest randomised controlled trial was positive and significant, the subsequent meta-analysis would be. These are all, in isolation, they perhaps might not mean much, but I think they all point to the fact that we can do systematic reviews quicker. We can get to the answers we need much quicker than 2 years and hundreds, if not thousands, of hours. You know, I'm doing my bit at Trip. I'm mucking around with machine learning in a hope. I don't think I'll succeed, but I don't mind. I just want to push the boundaries a bit, and I'm doing stuff where I want to do a job of getting. And the early results are quite good, and I might come back in a couple of years' time if the team will have me. And we're looking at getting sort of semi-systematic reviews done in about 30 minutes. That's a real bold claim, and I probably won't be here in 2 years, so I can say that here. And it's research in progress. But no, we're generally getting some really interesting results. And there was, again, Paul Gladue appears quite a lot in this. There was an editorial he wrote with Safnat and a few others about the automation of systematic reviews. I've spoken to Paul about that. And this is brilliant stuff. This is, I think, Paul, was it 2 weeks you're hoping to do your systematic reviews in? Is that your dream? Sorry, Paul's at the back.
A long-term goal.
A long-term goal. But I think this is where we're going. We can get there quickly. But what intrigued me most was the response to the Safnat paper in the BMJ by Cochrane. And I won't read it all out, I'll just read the one bit. We therefore need vibrant environments, so this is their response to Paul's paper. We therefore need vibrant environments for systematic review innovation and incentive structures that support rapid and broad release. 2 things struck me there. They've had 20 years and $250 million, and they've owned the space of systematic reviews for 20 years, virtually. And they're calling for an innovative environment. Surely you could have done it by now. But also the incentive structures. In the early days of Cochrane, I would have thought improving healthcare was incentive enough. but I think it just comes back to it being a big business now. Because I'm assuming they meant financial incentives. That saddened me. And the HTA world is full of people doing really rapid reviews, but I think there's an awful lot of research. And I'm not advocating that we do rapid reviews for the sake of it, or rapid systematic reviews. We need to be doing it in a research environment. But we've got to try, we've got to fail, because it's unsustainable, the current situation. And I gave the Chomsky quote earlier about authority, hierarchy and domination. And there's a second part to it. And unless a justification for them can be given, they're illegitimate and should be dismantled. Which feeds me on to my, in my abstract, it was a bit of a sort of be controversial in the abstract. Does Cochrane do more harm than good? You know, recapping on some of the sort of horror statistics, £150 million spent, $250 million. I would argue the relevancy is typically low. Well, it certainly is in my domain. 64% are out of date and it's getting worse. And we've got the thing, opportunity cost, which is often overlooked. When people are doing, it doesn't have to be Cochrane systematic reviews, but systematic reviews generally, could they be doing anything better with their time? And within Public Health Wales, I discussed, is it better to do 100 systematic reviews or 90 systematic reviews and 500 rapid reviews? And the irony is, and Ian would correct me because I'm using the word rapid versus systematic, because you can still do, it should be systematic reviews done rapidly. But we haven't got the evidence to answer that question. And I think we need to do more evidence. Evidence will solve this problem. And to finish up here, because I'd like to think I've generated some questions. And by the way, I'm deliberately not answering the question, does Cochrane do more harm than good? Because I actually think, for all my moaning of it, I do think Cochrane has done an awful lot of good. But I think the opportunity cost leaves it hanging. But Trish Greenhalgh, who many of you will know, wrote an editorial recently in Journal of Primary Healthcare. Why do we always end up here? Evidence-based medicine's conceptual cul-de-sac. Brilliant. I think Trish Greenhalgh is a wonderful writer on evidence-based medicine. And she taught me in St. Albans. I think it was a monastery about 15 years ago. Anyway, religion keeps cropping up in this whole 2 days. But she wrote, researchers in dominant paradigms tend to be very keen on procedure. They set up committees to define and police the rules of their paradigm, awarding grants and accolades to those who follow those rules. This entirely circular exercise works very well just after the establishment of a new paradigm, since building systematically on what has gone before is an efficient and effective route to scientific progress. But once new discoveries have stretched the paradigm to its limits, these same rules and procedures become counterproductive and constraining. That's what I mean by a conceptual cul-de-sac. And I think we are in danger of being driven down a cul-de-sac. Now, I think we should reverse and go a different direction, not as in a slow waltz, but as a good old fast punk song blaring on the car radio. Thank you.